primary immune deficiency disorders, because I have heard him talking about immune deficiency. I'm sure that is his favorite domain, and anywhere in India, if we have a discussion on immune deficiency disorders, Dr. Sagar is there. And he's the first DM in the field of pediatric immunology and rheumatology. He has authored a book on primary immunodeficiency made simple. He has trained at Jipmar PGI Chandigarh. He's got a lot of awards to his credit. Dr. Major General Amir Chand Gold Medal for research in pediatric lupus. He has got an attachment as observership at Destiny Institute, Genova, Italy, which is considered the largest referral center for pediatric rheumatology in Europe. A lot of publications to his credit, and an expert of a lot of clinical acumen. Dr. Sagar Bhattad is there with us to share his experiences, and welcome Dr. Sagar to this the Vibes Forum. Another dynamic youngster, Dr. Rajsekhar from Visakhapatnam, and very good friend of mine, always very active in Indian Academy of Pediatrics, and almost there for 20 years. And with a lot of with innovative thoughts and ideas. Whenever he used to discuss with him, I always get enamored of the way he discussions go ahead with what he can do for IAP, what we can do. And he is the past president of IAP Visakhapatnam branch, past vice president of IAP AP State, present secretary of Infectious Disease Chapter AP State, and he's a senior consultant pediatrician at the Giggles Omni Hospital, Visakhapatnam, Andhra Pradesh. So he is very, very active, and even in that WhatsApp group also he was reading from the front, and I believe you can contribute in a big way to the deliberations here today. Welcome Dr. Rajsekhar to the Vibes Forum.
Thank you, sir. Thank you for a nice introduction, sir.
Yes, I am privileged having you all around. And I am a close friend of myself and all of us from Chennai, Dr. Sudhakar. He has done his field, definitely domain is actually the developmental neurology and immunization, but still I requested him to join the team because we will have to learn from the general pediatrics, those who are in the medical college. He is attached to the Chengalpet Medical College, as an associate professor. So a lot of postgraduate teacher, they are currently managing all these cases in the medical college. So that similar inputs is badly required for a forum like this, where level 2 pediatricians are the main attendees. So he's a nodal officer for the District Early Intervention Center for CMCH. Developmental pediatrician, he has got a center for him on his own, Spinestone CDC Chennai, and he is undergoing board certified assistant behavior analyst course also. He's a certified trainer in many developmental platforms, and he has got a publications of Practical Pediatric Guidelines 2016 in JP. He is the secretary of the Chennai City branch right now, 2012-18, and again the vice president of Tamil Nadu State branch, secretary of Tamil Nadu ID chapter, national trainer for many UNICEF projects, currently steering committee member for RMCH project, resource person for Clinton Foundation. Lot of accreditations and lot of work is going on, lot of good number of community activities. That says so much about him. He is so active and vibrant in the pediatric as well as in the other domains. And we are so happy to have Dr. Sudhakar here. We are quite privileged to invite you to this forum, Dr. Sudhakar. Friends, 1 minute. So that's great, friends. We have got a great team ahead with us today. And I am not taking much time, it's already, but I'm so happy to introduce my great friends who have received my invitation at short notice, as Dr. Rashna has put it, hardly 4 or 5 days was given, but I believe they will do definitely the justice. They are going to have a great session here today. And I take your apologies for maybe I have to leave a little earlier. That's why Dr. Suma will be around with you to take it forward. And she is the ideal person, I believe, to take the questions and answer on her own or whenever the situation becomes a little tense. So I hope we'll have a good academic session here today. And it's over to Dr. Rashna Das to take over the deliberations. Over to you, ma'am.
Thank you, sir. We'll try our very best in spite of the very short time that we got. And I am very thankful to my panelists who also did a great job of responding and getting together this panel discussion. Thank you, Suma, again for being here, because I think the tough parts we will put on to you and Sagar. So the topic, as you see today, is the limp should not be the limiting factor. And though it says all about arthritis in children, I think 2 hours is not enough time to discuss the whole of arthritis. What we will try to do is we will do some case-based discussions and try to take you through some common scenarios and what the practicing pediatrician should have in mind, including the rheumatological disorders. So the panelists have already been introduced. So joint pain is a very common complaint in children, and this is from Dr. Suma's publication. I took the data that 15% of the general pediatric consultation is for some form of pain of the musculoskeletal system. So in the OPD, we have a lot of these patients who come in, and the pain in the musculoskeletal system, whether it's the joint or the muscle, can arise from a number of conditions ranging from benign to more serious etiology. So we will look at some of these etiologies today in the next maybe about an hour or so. So I'll start with the first case. We have this 4-year-old boy who was brought with fever and pain in the right knee joint for the last 10 days. There was swelling in the joint for about 5 days, and he was not able to walk for a day. So the parents got worried and brought him to the hospital. On examination, he was febrile, irritable, and he was always staying on the father's lap. Somehow we could manage to see the knee joint, and we saw that the right knee joint was swollen, red, and tender to touch with painful restriction of the movement. As you can see, very prominent findings in the knee joint. So Dr. Rajsekhar, this is for you. What do you think this case is? And any pointers we can look for? What are the possible differentials? And how would we proceed to investigate this patient?
First of all, I would like to thank the organizers of this meet, IIP Kerala, Dr. Remesh, for giving me this opportunity to be with you all this great evening. It's a very great evening because I'm finding that all the people, all the doctors are collected from throughout Pan India, and speakers also from Pan India. It's a great thing which Dr. Ramesh has done. Thank you everyone. So coming to this case, we have a 4-year-old child. The onset of symptoms are acute, and then there is a systemic feature of fever. And when we look at the joint is swollen, it is red, it is angry looking. So it points to me as a case of monoarticular arthritis. And most likely it may be a case of septic arthritis. Next slide. Coming to any pointers we have to take in the history is, suppose if I think it is a case of septic arthritis, then I would have liked to know where the infection has started from, because most of the cases of septic arthritis, there is a bacterium present. And when there is a bacterium, I would like to search for any other site of infection. The second history I would like to ask is if there is any history of trauma, if there is any history of penetrating injury. Had it been a rheumatoid arthritis joint, was there any prior injection put in that joint? So this history will point out something into my diagnosis, which I am thinking in my mind. The possible deed is, madam, next. So now we have got a child who is we have come into conclusion that there is a monoarticular arthritis. Let's see what are the other differential diagnoses which comes into our mind. A case of monoarticular arthritis, age is 4 years, but here the child is having a little bit fever. So suppose there would have been not much systemic symptoms, I would have pointed out as a case of quasi-articular rheumatoid arthritis. Then the second comes is there is a joint, there is a swelling. So is it a case of osteomyelitis? Had it been a case of osteomyelitis, then what would have been the joint which we see? The joint is full because the synovium is anterior place, so it is, the joint is more swollen. Had it been the bone, the overlying skin or the soft tissues, there would have been edema but not that much swelling. If there is a contiguous cellulitis, therefore then it will also look as a joint swelling. So it will also look like an arthritis, but we can distinguish by clinical examination whether it is a cellulitis or whether there is a joint involved or not. The other differential diagnosis may be a Lyme arthritis. In case of Lyme arthritis, there will be swelling, but what happens is that pain and fever will be less. Reactive arthritis. So suppose I will think as a case of reactive arthritis, then I have to point into the pointers of the history back. In case of reactive arthritis, I'll ask for the history, whether there was a genitourinary infections, whether there was any gastrointestinal infection, Then I can ask about the history of any inflammatory bowel disease, or if there was any history of pharyngitis. So these are the ways which I can think had it been a case of reactive arthritis. Sometimes I'll think of any immunological mediated arthritis, like if the child has taken any vaccines. Suppose if I can take a history of viral hepatitis, because they may also cause an arthritis. So this is the way I'll think of the history and then can come to the conclusion. Coming to the blood disease, one is the hemophilia. If there is an hemophilia, was there an repeated attacks of joint swelling, or was there any other joint swollen previously? So this way we can exclude the hemophilia. Sickle cell disease, we can know there must be anemia and there must be other previous history of vaso-occlusive crisis. By this way I can differentiate from septic arthritis. Next slide.
So, but in this child, since there is just an arthritis, it's
So
good
this is
presentation.
so this yeah. Next slide.
So you think the most possible diagnosis is
septic arthritis, because
septic.
unilateral monoarticular red looking angry looking joint.
Right.
So now to corroborate our diagnosis, we have got a history, we have got an examination done. Now we come into the provisional diagnosis as a monoarticular septic arthritis. And septic arthritis, mostly it is a monoarticular disease. Now to corroborate my diagnosis, what investigations have I got in my armamentarium? I'll use it. So everyone knows that there's a basic investigation, that is CBC, CRPSR. It is an infection. So when there is an infection, the leukocytosis will be there and acute inflammatory markers may rise. So CRP may be risen, yes, ESR will rise. This will come into some conclusion, add on in my diagnosis. Then I go for the blood culture, but septic arthritis blood culture will be positive only in 20%. But if I get positive, I can know the organism, it will help me in the duration of the treatment. Next, when I go to the joint proper, I can do a joint aspirate. Once I do a joint aspirate, what do I get there? I can go send it for culture. So with the blood culture, with the joint culture, my positive rate increases to 50%. Sometimes I may go for the multiplex bacterial PCR panel, which are available now. So this increases my sensitivity of diagnosis more, because this includes the Kingenella species, which are common finding nowadays. Then I'll put into the biochemical analysis. If biochemical analysis has been done, and then bacteria WC count rises, and if it is more than 50,000, again it points towards my diagnosis. Then what are the investigations left which I can do? One is the ultrasound. Ultrasound will show a joint effusion, and ultrasound will also help in guiding for the aspiration. The other investigation which are left is X-ray. Can X-ray help? Yes, X-ray can help. If you take an X-ray, there will be widening of the joint capsule, there may be soft tissue swelling, and there may be absence of the normal fat line. Does an MRI help? With this conclusion, we can straight away diagnose as a case of monoarticular arthritis. Suppose MRI, what is the role of this MRI? MRI is taken just because in case of children, what happens that the contiguous osteomyelitis should not be, it should be added on, because this helps in my treatment. If suppose it is arthritis of the shoulder, arthritis of the elbow, arthritis of the hip, arthritis of the ankle, what we have to do, we have to do an MRI or CT. What happens? It helps us in diagnosing in the contiguous arthritis, because in these cases, the anatomy is such that the metaphysis is basically intra-articular. As the child grows, so the normal anatomy of the adult anatomy appears. So we should not miss a case of osteomyelitis. And especially when it is a child neonate, we have to do an MRI, because the joint as well as osteomyelitis of the femur, that should not be missed. If we miss it, it will create a havoc. The other diagnosis that is left is radionuclide scanning. It is more sensitive, but we are not going to. So MRI, CT, and radionuclide scanning, we keep it aside. But being a child, depending on the site of the infection, as I told you, you have to do an MRI if it is a knee arthritis, hip arthritis, ankle arthritis, shoulder and elbow arthritis.
So excellently described. And to just tell you what we found in this case, the ESR and the CRP were high. The joint was aspirated and it revealed pus. And the joint fluid analysis showed 12,000 cells, but there were a lot of degraded cells seen. Gram stain showed only pus cells, and the joint fluid grew Staphylococcus aureus. So from this case, what we would like to emphasize is that in case of a monoarthritis, one must always think of septic arthritis, rule it out, and history of trauma, as Dr. Rajsekhar has said, is very important. Because sometimes this is the point from where the bacteria enter and cause arthritis in the adjacent joint. And joint fluid, of course, is very, very important because it gives you a lot of information. And if you culture it, you can get the organism. So we come to the next case, an 8-year-old boy who is very active in sports, has pain of both knee and ankle joint. There is no significant fever. He is able to perform regular activities. He was seen by a local physician who saw the patient and advised an ASO titer, which comes as 380 units per ml. So he starts this boy on injection Penidur. After the first painful injectable Penidur, the parents decide to take a second opinion and bring the child to you, Dr. Sudhakar. So can you tell me, is this acute rheumatic fever? I think that's the reason Penidur was started. And is Penidur justified? And how would you proceed in such a case? Dr. Sudhakar.
Yeah, thank you. Thank you for giving a simple case for a developmental neurologist. But of course, in a general practice, you can come across children with this kind of pain, musculoskeletal pain, 15, even few studies has shown up to 35 also, 35%, 15 to 35% are coming with some kind of musculoskeletal pain. So instead of going through just by our own gut feeling or something, any practitioner has to follow the criteria. It is obvious anyone can make it. This is not it cannot be an acute rheumatic fever, and it is not at all justified to start a Penidur in this case. But same time, we also need to justify why it is not. So how to proceed in such? First, going through my history, it is an 8-year-old male child. Actually, it is not arthritis. You have mentioned clearly it is an arthralgia. And in the history, there is no preceding events have been reported. And there is no restriction of movements, and there is no restricted activity, as well as there is no exertional dyspnea kind of thing. Actually, there was no reported skin rash or any other pain has been reported. Okay, even eye pain has been not. So I put in a simple way, it may not be related to this case. Actually, it is a rheumatological approach. But the point is, I want to mention, whenever a child comes with a pain, you need to take off everything. It may take only 5 minutes for it. So a proper history, then a proper examination. It may be from the head to foot also. So you look whether there is any swelling. If there is a swelling, if it is more than pain or pain is more than swelling, that's going to differentiate your thing. Then what type of joints? Is the large joints or small joints are involved? Which one started first? Is a migratory and non-migratory? Then what is the duration? Whether it's an acute or chronic, or whether there is any there, or eye pain is there, and is there any bleeding diathesis, history of bleeding trauma? It may be a simple case, but still you take spare 5 minutes to get that. Then the investigation I'm not going to discuss in this case. It could be a serological, as well we'll be discussing later in other cases. Next, madam. So what is the diagnosis here in this child? It's a very good question. It's an open question. It's a very open question actually. From a practitioner, I would say it could be 3 things. It could be a simple exertional pain. Maybe the child is playing a lot. Actually, any child, especially with the 3 to 5 years, they'll be having this kind, but it can extend even up to 12 years. These children having excessive activity is going to have this kind of increase. So more the activity, more the pain. And many children will have that actually. Even I have come across a case called pain amplification syndrome. The child is keep on limping with the pain. I couldn't make out any diagnosis. Parents are keep on doing shopping there. And finally, when we're selling it's normal, they are not ready to accept it. When we say pain amplification syndrome, they are very satisfied. Finally, treatment is going to be nothing. It's only in paracetamol. So comment on ASO titer. It's very, very important. This doctor has started based on the ASO titer because it's very alarming. It's more than 200 TOTS unit or international unit. Yes, we need to consider the ASO titer if you're a practitioner. But ASO titer is not a diagnostic of rheumatic fever. It indicates ASO is nothing but an antibody against the streptococcal antigen. So we need to take a history if there is any past history of throat infection or skin infection. So any streptococcal infection is going to increase the ASO titer. So, and we can say that ASO titer can happen in any infection. So we need to follow the Jones criteria. Please go to the next slide, madam. So this is a case of arthralgia secondary to excessive use. ASO alone cannot be used to start. So this case repeatedly says that whenever you make a diagnosis, we should follow the criteria to make a diagnosis. So in the modified criteria, the Jones criteria is a major manifestation, minor. We have a PEX. We have a major manifestation in pneumonic PEX, polyarthritis. It's a migratory polyarthritis, and in India falls under the high prevalence area actually. So in India, even if not polyarthritis, even in monoarthritis also has to be considered actually, if I'm right. Okay, arthritis, then erythema marginatum, carditis, chorea, and subcutaneous nodules. And minor manifestation, the should have fever, arthralgia, lab investigation, elevated ESR, C-reactive proteins, and ECG prolonged PR interval. So one major with two minor are any two minor with one major, two major or one major with two minor, then but the child should have a supporting evidence of a preceding streptococcal infection in the last 45 days. That is the most important. So this doctor has started not with the criteria, he has started only with that ASO titer is totally wrong in this case. So growth pain or this excessive usage pain should not be omitted at any cost of time.
Thank you. I think you've described most of the things that I wanted to bring out of this case. And what is important is that though we do not see acute rheumatic fever or the joint manifestations of acute rheumatic fever so often these days, yes, but in case you are confused, then always go back to the Jones criteria. So yes, I think that is something we must keep in mind, because as you can see, this is ASO is only a indicator of a preceding streptococcal infection. So thank you, Dr. Sudhakar. I think you've taken this case very nicely.
Thank you.
Now we come to the next case, a 7-year-old boy. He's been unwell since 1 year of age with painful episodic swelling of the right knee joint, as you can see here. And this is now fixed for 3 years. Occasionally, there is also a history of swelling of the right elbow with trivial trauma. And he has been referred to you for starting of methotrexate, Dr. Lakhan. So any further evaluation you'd like to do before giving him the methotrexate? Anything extra you'd like to know? Dr. Lakhan? Is Dr. Lakhan there, or he's exited? Dr. Lakhan, you have to unmute. You have to unmute. We can't hear you, Dr. Lakhan. You have to unmute.
Hello.
Yeah.
Yeah, thank you, Dr. Rashna, for selecting a simple case for me too. I think the difficult cases you have kept for Dr. Sagar. This boy, as you said, has no fever, and there is a onset of the illness since the age of 1 year in form of repeated involvement of one joint only. And there are no signs of arthritis in form of fever or malaise or any other inflammatory illnesses. So I would not like to consider methotrexate for this child at all. This child seems to be a case of hematological disorder, probably hemophilia, because the onset of arthritis, joint involvement is since the age of 1 year, and in hemophilia, the usual age of joint bleeding, that is hemarthrosis, is 1 year. When the child starts crawling and starts walking and starts falling. So repeated involvement of one joint in form of hemarthrosis has made this joint a target joint, and for few years the movement of the joint have decreased dramatically. It has almost become fixed. So this is a case of hemophilia. I would like to take the history of hemophilia on bleeding disorder in other family members, and that X-linked recessive inheritance I would like to establish, though in around 30% of the cases in our country, it can be de novo, and it can be because of the new mutation. So I will proceed with the CBC to rule out thrombocytopenia and to rule out leukemia. I will go for bleeding time. Uh, I will go for prothrombin time, and of course partial thromboplastin time, that is APTT. If APTT is prolonged and rest of the investigations are normal, then it is a case of hemophilia A or hemophilia B. And in that case, I would go for estimation of the factor 8 and 9, and that will tell us the diagnosis. So in such a cases, even if we think of a rheumatological disorder, we must go for ruling out the hematological causes before starting methotrexate.
So in this case, the APTT was prolonged and a factor assay was done, factor 8 assay, which was less than 20%, and the diagnosis was hemophilia A with hemarthrosis. So what I wanted to emphasize by giving this, as Dr. Lakhan said, simple case, but very important, is that a repeated arthropathy affecting a single joint, we must always think of a bleeding disorder, because it is seen that in these cases, a particular joint becomes the focus of all the bleeding which takes place. So with this, we go to the case 4, 5-year-old girl with a right knee arthritis for the past 3 months. And this is what has been found on examination and some more other findings. I'd like Dr. Sagar to take this case and tell us, what do you think this is?
Thank you, ma'am.
Sagar.
Yeah, thanks, ma'am. And thank you, Ramesh, sir, for involving me amongst the eminent panelists. So this is a 5-year-old girl, and we can see that this girl has presented with right knee arthritis. So I would want to highlight few basics when we are dealing with arthritis or arthralgia. The number one question I would always ask in a child who presents with musculoskeletal symptoms is, it is very essential for us right at the beginning to differentiate whether this is arthralgia or arthritis. I would believe in general pediatric practice, majority of children who are brought to us have arthralgia and don't really have arthritis. And if at the first point we go wrong, we will tangentially investigate them in a very different direction. So the very first thing I would like to do in any child who is brought to me with joint pain is to examine the child and find out if there is joint swelling or if there is joint stiffness and restriction of movements. So if this child does not have a joint swelling or stiffness and it is only arthralgia, then the differentials would be very different. The moment I know it is arthritis, the next question I would want to ask is it acute or is it long standing? That is less than 6 weeks, more than 6 weeks. The moment you have a child who has arthritis for more than 6 weeks, most of your usual differential diagnoses are out. It's not usually viral arthritis, and it's not usually rheumatic fever, the most common stuff that is taught in pediatric practice. And the moment you have arthritis lasting for more than 6 weeks, one of the most common differentials is juvenile idiopathic arthritis. I would also want to highlight that these days we don't use the word JRA, we use the word JIA. Matter of semantics, but we should use the right term, juvenile idiopathic arthritis. Now coming to this child, this is a, I would say, toddler, a girl child, comes with monoarthritis for the past 3 months. There could be a long list of differential, right from tuberculosis, which can present with chronic monoarthritis, but the child does not have fever or any constitutional symptoms, I believe. Second thing is juvenile idiopathic arthritis is a strong possibility, and since it is a single joint, we would like to use the word oligoarticular GIA. That's what we call. And the third possibility, since you have highlighted findings like nail pitting, as you can see in this picture, there are pits on the nails and a single finger is swollen completely, what we call dactylitis. The middle finger appears to be swollen here. So if you have a child with arthritis, dactylitis, nail pitting, then the diagnosis should be psoriatic arthritis or psoriatic arthropathy. Naturally, the next question would be, do you have a family history of psoriasis? So if you have a child with psoriasis and arthritis, it's a straightforward diagnosis, psoriatic arthritis. But even in the absence of psoriasis, if you have nail pitting or if you have dactylitis, think about psoriatic arthropathy. Now, how do these children present to us? These children with psoriatic arthritis have usually two types of presentations. To make it simple, just remember a toddler girl, a girl who is less than 5 is brought to you with lower limb arthritis, usually few joints, large joints. It could be oligoarticular JI. I'm only talking about chronic arthritis, and maybe psoriatic arthritis. And if you have dactylitis, nail pitting, or involvement of distal interphalangeal joint, you are likely dealing with psoriatic arthritis. And if you order an ANA test in some of these patients, it would be positive. And these children are at increased risk of uveitis. Please get a regular eye examination done by a trained ophthalmologist who is experienced in handling young children. And these children can also present to you after the age of 10, essentially with lower limb arthritis. And this would very much look like the enthesitis related arthritis or the juvenile form of ankylosing spondylitis, to make it simple. And these children are at increased risk of having spine involvement. So the only thing I would have to highlight is, in every child with arthritis, look for nails, and also dactylitis is something that we must be looking at.
So I think Sagar has described a very important point, that when you're having a joint involvement, don't forget to look at the nails, because sometimes the nails can give you the clue to the diagnosis, as was in this case. So thank you, Sagar. And I think we'll go to the next case. Again, we go back to Dr. Rajsekhar. 9-year-old girl, fever, swelling and pain in multiple joints for about 6 weeks now. Child is tachypneic and tachycardic. When she was examined, had a normal BP, painful swelling of the knees, mild splenomegaly, no bleeding spots, no lymphadenopathy. The rest of the systemic examination is unremarkable. So what additional information would you like to elicit from the history, and any specific points in the examination, and what investigations?
So to sum up,
Yes.
we are having a case. A child is there. There's a fever and joint pain. Multiple joints are involved, and the duration is a chronic one, around 6 weeks. So child with 6 weeks fever, systemic symptoms, and with joint involvement. Fever, joint involvement, and 6 weeks duration. So what are the conditions? First, I would think of it. So what are the conditions? There are 3 conditions. One, it may be inflammatory, one, it may be infected, or it may be malignant. So what is the inflammatory things? So is it a case of systemic onset juvenile idiopathic arthritis, or is it a case of SLE, or is it a case of malignant? These are the 3 things. I'll think of it and then I'll proceed. Madam, next slide. So in this additional history, I would like to ask was whether the child is having a weight loss, whether there is history of fatigue, loss of appetite, sleep disturbance, night sweats. Was it there or not? So this will additional help in my history taking and in my examination points. Then what would I like to examine? In the examination, already Madam has told the answers has been given. In the examination, there was only a splenomegaly, but there was no any bleeding diathesis. So is the child having any bony tenderness? So in case of malignancy, what we think, whether the bony tenderness has to, it is basically affecting the arms, legs, back. So I would like to look whether in these areas there are any tenderness. So this will again help me in my diagnosis to exclude all these 3 cases. Next.
Great. So when we did the investigations, this child had a hemoglobin of 6.2, count of 6,300 with mostly lymphocytes, platelet on the lower side at 1.5 lakhs, high ESR, CRP was 59, and the ultrasound showed splenomegaly. And since you asked for the other test, so in the peripheral smear, there was 70% blast, and a bone marrow aspirate showed these huge number of blasts. So a diagnosis of ALL was made. So I think before we come to the takeaway points from this case, any comments on this X-ray, Dr. Rajsekhar?
In this X-ray, we are finding a lytic lesion, madam. So this lytic lesion, as we have got the case, this is seen in case of malignancies. In leukemia, we find this lytic lesion. The other condition we can find is aneurysmal bone cyst or solitary cyst, or it may be in metastatic disease also of the breast, lungs, kidney. So these are the things where we find a lytic lesion in the bones. And
Sagar, any other condition you can find these lytic lesions? Unmute.
Yeah, sorry. These lytic lesions, I think you could obviously, I think we have highlighted leukemia as a strong possibility, but it could also be seen in conditions like LCH. Langerhans cell histiocytosis is a possibility that I would keep in mind. And definitely with this setting, what we have described, leukemia becomes a prime possibility.
Any other panelists? Dr. Lakhan, what do you think? Any other differential for this lytic lesion?
Are you asking for osteoma or something of that sort? But I don't
Yeah, in such a,
Could it be any tumor, madam? Osteodysteoma or something?
Yeah, it could be tumor. It could also be tuberculosis. In our, not in this case.
Tubercular
But
osteomyelitis.
in our country, I think when you have joint pain and if you have these kind of lesions, then sometimes you'll end up having a diagnosis of tuberculosis. So I think most important point from this case is that acute leukemia is a great masquerade of arthritis, and whenever we suspect and rule out with the other history and clinical findings, we must, in some of these cases, do a bone marrow aspirate so that, we don't land up starting steroids or methotrexate. Because once you start steroids in these kind of patients, then the entire diagnosis becomes a problem later on. So now coming to the next case, we have this 3-year-old girl limping for 7 to 8 weeks. Parents notice that the child is unable to get up from the bed and is very fretful in the morning. She gets playful by mid-morning, and they also notice that gradually one thigh appears to be thinner than the other. And on examination, the right knee and ankle are swollen, and so is the left third finger. So Dr. Sudhakar, this case is for you. Any additional questions you want to ask to pinpoint the pattern of the arthritis? Any focus areas while examining, and what investigations?
Sorry. Again, as I told from the beginning, any child with arthritis, we have to go for thorough history of the child, history of any fever, history of any preceding events. It could be bleeding disorder, it could be trauma, or it could be any infection induced, or there is any family history of bleeding disorders, or any eye involvement or any skin rashes. That's what I have to go for it. Other areas, yes, we have to always go for the tip to toe. We always say bless the child from tip to toe. So you have to look for nodules in the thing. You have to look for other rashes and thing. What investigation? I'll go for the next. Please go to the next slide. So already told history of like fever and thing. And for ophthalmic examination also needed, and investigation, complete blood count, a peripheral smear, ESR, SARP, ANA, and rheumatoid factor I need actually. Next, madam. So coming to why we want to, this case is an oligoarticular JAA. So why oligoarticular? This case is actually, it is not with the rheumatologist, it's for every pediatrician has to come across, because many times it's a very common scenario. And among the arthritis, again, based on the ALR subtypes, 50%, up to 50% of children are going to have an oligoarticular JA. That's a very most common among the arthritis. Otherwise, this next common will be in Sogia child. My child is 3 years old. So considering the age, it is two, and a joint number of joints is 3 joints are involved, especially in the knee, ankle, and the middle hand is involved. So 3 joints involved. Duration is more than 6, and age is 3 years. So 2 to 4 years, we consider 2 to 4 years. 3 conditions you have to do. First, it is an oligoarticular JAA, or it could be a rheumatoid factor negative polyarthritis, which will be presenting with a biphasic presentation, or it could be a psoriatic arthritis also, which have a skin manifestation, or it could be presenting with an uveitis also. So considering the age and female preponderance. So coming to 3 diagnoses, most common is oligoarticular JA based on the number of joint, type of joint involved, as well as the uveitis, absent uveitis. If it is absent, it is a JA associated with the uveitis different. Next, madam.
Good. So what we wanted to tell here in highlight in this case is that the duration, the number of joints involved, the way the joints have been involved, whether it is additive or migratory, these are important points to arrive at a diagnosis. So since Sagar is here, Sagar, would you like to talk about a little bit about this P-GALS, which is supposed to be an important tool these days to assess the joints?
Actually, every postgraduate student should be thorough with the PGAL system. It's a very let me add as a pediatrician. So it is a very simple musculoskeletal system examination. You can make the child to say temporomandibular junction, cervical spine, and your lumbar spine, sacral spine. You can check all these things by making the child to for a toe walk, heel walking, making the child to look up to the ceiling. Actually, raise the hands. And it's a very simple system where we won't be able missing that joint involvement in a child with a musculoskeletal pain. So please add more then I will add my other point for the JE.
No, I think sir has covered it well. So basically, I think it's a simple tool. And as we say, we do cardiovascular system examination, CNS, respiratory. So somewhere I think in our training, I don't know these days, must be it is added that musculoskeletal exam should also be one of the systemic exam. And probably PGAL screen is a part of it. And those people who practice it regularly will take 2 minutes, just only 2 minutes to do a quick screen, and it is only a screening test. The moment you do it, you find anything abnormal, you should do a detailed exam. And I can only tell you, go to a YouTube video, look at the PGAL screen, spend 10 minutes on there, start using it. We can all use it.
Excellent points. I think for all the pediatricians as well as the postgraduate students specifically.
Madam, I want to add few more points for the students, postgraduate students.
Yes.
JA is always a diagnosis of exclusion. That's we have to make it very clear. It is a diagnosis of exclusion. After doing all the other investigation, make a diagnosis of JA. And it could be reactive arthritis in this age group because they are coming across lot of viral infections also possibility. And never forget the chance of last case we had discussed about leukemia. Whenever you come across a child, a small child, always look for the pain is more severe compared to the arthritis. Even if putting a blanket over the legs, the child will be very throbbing pain will be. That's very characteristic. And in India, never forget the tuberculosis and all the other streptococcal infection. And even Kawasaki disease also can mimic present like this actually. And even certain immunodeficiency also can present in arthritis. So whenever think of making a diagnosis of oligoarticular JA as a pediatrician, we should think this about all these things and do the acute phase reaction investigation and ANA as well as rheumatoid factor. Thank you.
Very good points. I think this is what the postgraduates specifically should understand and keep in mind. So now we come to the next case, a 16-year-old boy with fever for about 5 days. He has pain in the right hip for 3 days, inability to walk for a day. In the past history, the mother says that he had a similar history about a year back. He responded to some treatment given by the local physician. And that time he was also found to be anemic and was given a blood transfusion. On examination at this admission, he was febrile, pale, and he had a splenomegaly and severe tenderness of the right hip with restriction of movements. He would not allow the right hip to be examined. So Dr. Lakhan, this is for you. Any additional questions you would like to ask, and how would you proceed to investigate this child?
Because he is an adolescent boy and is having a short history of 5 days only of fever and pain in the joint. So looking into this, I would definitely consider, because he is an adolescent, so reactive arthritis should be considered in this age. And the enthesitis related arthritis is also one of the possibility, but because the child is having a splenomegaly and there's a past history of a similar involvement arthritis and a history of blood transfusion also. So I would consider a hematological disorder in this child. And because in my area, there's a lot of tribal population. So we usually come across such cases when the children in this age come with arthritis and history of blood transfusion and splenomegaly. So splenomegaly in this case could be because of sequestration in the spleen. I would consider sickle cell disease in this child because the child had arthritis 1 year back and required blood transfusion because if there's a splenic sequestration, then the hemoglobin falls by 2 to 3 gram per deciliter. And the pain in this child is because of avascular necrosis of the femur head, and that leads to pain and severe, limitation of the movements. In such cases, we have to differentiate whether it is an inflammatory or a non-inflammatory, means mechanical cause of the arthritis. Inflammatory means we have discussed a lot of cases of arthritis, especially GIA, when the child has more pain in the morning and is fretful and has difficulty in getting up from the bed. But if it is a mechanical case like fracture or avascular necrosis, like in this child, the pain will be more when the child moves the limb. So the arthritis with fever, because in sickle cell disease, fever is common, and fever is a very, very alarming thing, because they have a functional asplenia. Though the spleen is enlarged anatomically, you can feel the spleen, but there is a functional asplenia. So severe infections with influenza, pneumococcus, meningococcus, they can occur. This child perhaps is a case of sickle cell disease with splenic sequestration and avascular necrosis of femur. We would go for CBC, in which anemia will definitely be there. We will go for sickling test, that is positive, as you already shown. And because he's a native of Orissa, means sickle cell is a common problem in the tribal population, and children can present at this age also, especially when there is a heterozygous condition. In our region, like in Udaipur region, we see a lot of children with sickle cell thalassemia, who do not present typically with thalassemia like presentation, means regular transfusion requirement, and they also don't have those severe pain crisis as in typical sickle cell anemia. So there's a heterozygous condition, sickle cell thalassemia, or those cases can present at this age also. So of course, the HB electrophoresis is the final diagnostic investigation, which will show increased hemoglobin S, and if there is a heterozygous condition, then fetal hemoglobin and hemoglobin S both will be raised. MRI will be very helpful in diagnosing the avascular necrosis of the head of the femur, and as you have already shown in this picture, there is a cortical irregularity of both femur, and there is altered marrow texture affecting right femoral head with extension to the neck and visualized proximal femoral shaft. So my diagnosis is sickle cell crisis in this child.
So another very important disease in our country like ours, because there are patients of sickle cell anemia scattered over some populations in specific areas. And this is something that we must remember, especially in the setting of anemia, along with, the other differential of an acute leukemia. So here it is very, very important to understand that the history helps to pinpoint the suspicion towards a hematological cause, especially if you know the tribe, if they're from a particular tribe or from a particular region. And as I said, sickle cell crisis is especially important if these patients are coming from a sickle cell endemic zone. And if this child could be anywhere in India, maybe he's originally from Orissa, but he can stay anywhere in India. So this is something which I thought we must, keep in mind whenever we see these patients of acute bone pain. So coming to the next case, this is for Sagar. 14-year-old girl has pain and swelling of small joints of the hands for the last 2 to 3 months. Some stiffness and pain, which is more in the morning, lasting for about a couple of hours. She also has a swollen and tender right wrist and no systemic symptoms, and gets partially relieved with non-steroidal anti-inflammatory agents. So obviously this child has significant arthritis. What I would like you to tell us is how will you categorize the arthritis in this child, and any specific investigations that will help. We talked about rheumatoid factor briefly, so anything related to that or any anti-CCP. Sagar.
Yes, ma'am. So basically, as you can see, this is an adolescent girl. And I think right from the beginning, we have been talking about basics of history. So I would put it simple. Always look at the age and the sex of the child, whether it is boy or girl, because our broad differentials change whenever we start looking at like that. So this is an adolescent girl, number one. Number two is that there is polyarthritis. By definition, you say 5 or more than 5 joints, but I don't think that is more important. You should look at the pattern of joint involvement. So here I can see that the small joints of the hands, when I say small joints, the metacarpophalangeal joints or the PIP joints are affected, and the wrist joint is affected. So whenever you see polyarthritis, whenever wrist joint is affected, and whenever you have small joints of the hands that are being affected, so you are looking at a pattern wherein there is polyarthritis with predominant involvement of these joints. That's the number two. And number three is the duration. Again, for example, a very short history of week, one may think about a simple etiology like viral, but then here we are dealing with something that is going on for months together. So this is a history of 3 months. So symmetric polyarthritis in a 3 month, for 3 months in an adolescent girl, I would definitely look at a possibility of polyarticular GIA. So this is juvenile idiopathic arthritis, likely polyarticular. However, as has been highlighted n number of times, that because you need to look for systemic signs, and as has been highlighted, there were no systemic signs. Probably I would be asking for oral ulcers, hair loss, and malar rash, say, to rule out SLE. So I'm just giving an example. So like that, you always rule out systemic symptoms, no prominent systemic symptoms, polyarthritis, a pattern like this is likely a polyarticular GIA. We would ask for a rheumatoid factor, but let me tell you, rheumatoid factor is positive only in 5% of children with GIA. So whether is rheumatoid factor positive or negative does not essentially change my diagnosis, neither my treatment at the beginning. What if only tells is that if the child is rheumatoid factor positive, the prognosis is going to be little serious. I mean to say, it's not I'm going to have a good prognosis, I'm going to treat it aggressively. So do not ever base your diagnosis completely on rheumatoid factor, number one. And I would not really go into theoretical aspect of this. I will just say polyarthritis can be RF negative, RF positive. RF positive polyarticular GIA essentially presents in adolescent age group, whereas RF negative can even present in younger age. And please examine the neck. Many of these children, when you examine in detail, you will realize that their neck movements are restricted. They won't actually come out with this complaint, but when you ask them to look at the ceiling, they are not able to do that. So that means cervical spine can be involved. And also examine the jaw, ask them to open the mouth and see if there is tenderness over the TM joint. This can be definitely involved in polyarticular GIA. Now, a small proportion can be RF negative, and you can, especially in adult practice, they would use anti-CCP, because if it is positive, it essentially behaves as RF positive polyarticular GIA. In pediatric practice, the role is debatable. I will leave it there. And I think, again, I would only highlight that just counting the number of joints is not important. If you have symmetrical arthritis involving MCP, PIP joint, the wrist joint is affected, this is likely polyarticular GIA. These children should be immediately either referred or started on DMARDs, and especially if they are RF positive, then they need more careful and aggressive treatment.
So, Sagar, when you look at such a number of joint involved, then you get really confused as a general pediatrician. So I would request you here that you would take up the differences between the various types of these juvenile idiopathic arthritis in a very simplistic way, so that it benefits the general pediatrician.
Yeah. So I think I would want to definitely remember my professor here, Professor Surjit Singh, who trained me. The very first time I heard his talk, I realized GIA is not difficult. It is made difficult by the way it is being taught or it is being discussed. So most often people feel we have to do a long battery of tests to diagnose juvenile idiopathic arthritis. I think the basic block is, number one, we feel this disease is rare. Let me tell you, the most common cause of chronic arthritis in children is juvenile idiopathic arthritis. And so any busy practitioner cannot say he has not seen a child with GIA. It is not possible. That means we are underdiagnosing this condition. Many of these children, unfortunately, land up with orthopedicians. This is not a domain of orthopedicians. They are going to put needles, they are going to biopsy these children. Essentially, most often there is no role of a aspiration of a joint or a biopsy of the synovium. So the moment a pediatrician refers a child to the orthopedician, it is a disservice done to the child, because this child is now going to get investigated in a very different fashion, a surgical fashion, which is actually not required in these children. So these diseases are common. Most often they need very few investigations, and there is a pattern. So let me go through this pattern and tell you how easy it is to diagnose. So the next slide, you can see this is the classification given for, say, juvenile idiopathic arthritis by the International League, ILR. They say oligoarthritis, RF positive, RF negative, systemic GIA, ERA, psoriatic, undifferentiated. No, this is not what we want you to remember. This is absolutely making things difficult, making you feel that this disease is to be managed only by a rheumatologist. I personally strongly feel most pediatricians can diagnose arthritis and can at least start the first line treatment. So let me go to the next slide. If you see a young girl, when I say a young girl who is, say, 5 or less than 5, in fact, many people feel that arthritis does not happen in young children. I have seen parents when they're referred, and if I say 3-year-old girl is having GIA, they look back at me. So sometimes you have to even convince the pediatrician that yes, GIA does happen in a 3-year-old child. So that is the first difficulty. So when you see a girl, it can happen in a boy, but more commonly in a girl child who is preschool age, comes to you with lower limb arthritis, maybe the knees, maybe the ankles, and the history is more than few months, say more than 6 weeks. This is the most common diagnosis here would be oligoarticular GIA. We have discussed TB and other things, but oligoarticular GIA, here the simple thing you do is the only investigation probably is ANA, because if the ANA is positive, the risk of uveitis is very high. These children should be subjected to regular screening of the eye. That's all. Now there is a second child, he has got knee involved, ankles involved. So you will again say this is oligoarticular, but this is a 12-year-old boy. The difference between the first and the second child is the first child is a toddler girl, the second child is an adolescent boy. An adolescent boy with lower limb arthritis, the most common diagnosis would be ERA, enthesitis related arthritis. Many of these children are HLA-B27 positive. Probably that's the test I would look for, and they would have symptomatic red eye. Some of these children can progress to develop ankylosing spondylitis. Most often they don't have spine involvement in childhood. The third thing is, which we discussed already, adolescent children, especially girls, coming with symmetric arthritis, especially involving small joints of the hand. RF may be positive. This is RF positive polyarticular GIA. And we will discuss another case wherein children coming with lot of systemic symptoms, high fevers, rashes, and arthritis is systemic GIA. So if we just follow these patterns, do simple tests, sometimes ANA, sometimes rheumatoid factor, and sometimes HLA-B27, not in all children, we can easily diagnose them and treat them. Thank you.
So I think very important is the last box here, that study of the pattern, associated systemic features will often help you in reaching a diagnosis. Very nicely put, Sagar. So I'll come now to the next case. A 12-year-old girl presents with swelling of small joints of the hands for 3 to 4 months, has morning stiffness, low-grade daily fever for about 6 weeks, complaints of poor appetite and weight loss for over last 8 to 10 weeks, and on examination has symmetrical joint involvement. So Dr. Rajsekhar, what additional questions would you like to ask in the history? Do you think this is polyarticular GIA like the previous case? Any specific findings you would like to look for, and the investigation to confirm your diagnosis? Dr. Rajsekhar.
Yeah. So first of all, we have discussed the same thing. This type of case. This type of case has been discussed. This type of case, the previous case was same. Adolescent girl, fever, and involvement of the joint, and a chronic duration. So same differentials come again here. Is it a case of Sogia? Is it a case of malignancy? Is it a case of SMG? 3 things are here. Now coming to the inflammatory arthritis, one pointer we had got is what? It was a morning stiffness. So early morning stiffness points towards the inflammatory arthritis, number 1. Then comes the question, if it is an inflammatory arthritis, Then what are the other things which we have to look for? If we go from the top to bottom, next slide we can see. Yeah, if we go from the top to bottom, we look for we'll ask for any case of neuropsychiatric symptoms. Is there is a history of headache? Is there any history of seizures? So this will point towards our diagnosis. Then if we examine from top to bottom again, we see any case of rash, especially if it is a malar rash, and open the mouth, see for mouth ulcer, palate ulcer, examine for any lymphadenopathy, then abdomen you examine for any hepatosplenomegaly, then look at the blood pressure, see for any hypertension present, and go for the important ocular examination where you may find optic neuritis and episcleritis. If any of these features are fitting it, there is a polyarticular arthritis, fever is there, and a adolescent girl is there, morning stiffness is there. With this type of features, then we can come into the other group of diagnosis, that is SLE. We may think of it as a case of SLE. Then we have to proceed with the investigations to point out our diagnosis. Next. So what are the investigations which we can do in SLE? So we start investigation on basics. With the basics, we look at the CBC. In the CBC, what we find out? We find for the cytopenias, whether if there is an anemia, if there is an leukopenia, if there is a thrombocytopenia. If these are present, it will be pointing more towards an SLE. If there would have been leukocytosis, if there were thrombocytosis, then it would have gone into the SOGIA. Then comes to the CRP and ESR. CRP elevated in SOGIA, but in case of SLE, the CRP is normal. ESR elevated SOGIA, ESR is elevated in SLE also. But CRP normal, ESR elevated, we'll again think our diagnosis fitting into SLE. If you are thinking of SLE, the next investigation we order for is the ANA. ANA should be done by IF method, not by the ELISA method. Once ANA has come positive, we'll go for the specific diagnosis, that is anti-double stranded DNA. If that is coming positive, then we'll think it is a case of SLE. We go for the serum complicated other diagnosis with C3 and C4 are decreased. Go for the urine examination, because the most important finding, adolescent girls, sometimes they may present with only nephrotic syndrome, because lupus nephritis presents as a nephrotic syndrome. You don't have any other features, joint pain and fever. Look for the urine examination if the kidney is involved. Next.
So in this case, we found that the ANA was positive. It was speckled. A dsDNA was also positive. She had low complements. And so as you have described, this is a case of SLE. So what we have to remember here is that if there is joint pain with systemic symptoms, especially in a girl, then we need to rule out SLE. One more thing that we have to, which Dr. Rajsekhar has said, and I'd like to reiterate, is that in these cases, we must also always look for renal involvement, because sometimes the renal involvement is silent, and depending on the class of the nephritis, the prognosis will also matter in these patients. So we'll come to the next case now. 17-year-old boy came with swelling of the left ankle, and he was limping for about 4 weeks. He has no fever. So Dr. Sudhakar, this is for you. In this adolescent boy, is there any additional question which should be asked? And what investigations do you think? Just simple 3 things. 17-year-old boy, swelling of left ankle for 4 weeks, but no fever.
Actually, question looks very simple. A single joint adolescent boy, okay, no fever, no systemic manifestation. It's like an examination for myself. Okay, I'm attending an exam among the rheumatologists actually. So I can go in any way now. I can take it as some monoarthritis. I can consider the adolescent age group actually. So let me go through that. We are living in India. Previously, when in India, we always consider tuberculosis the first diagnosis for whatever it may be. Head to foot, we always think about tuberculosis. In Western countries, we always think about sexual disorders. So Westernization of India is making us to think in a different way. Now we also need to think about the other causes other than tuberculosis. So let me put away other histories. We need to ask for the fever. As you already told, there is no fever. Is there any weight loss, morning stiffness, restriction of movement? It is looks like it for any other arthritis, but it has some value in this case also. So, is there any trauma, recent sore throat, gastroenteritis, red and painful eyes, history of sexual behavior, first discharge from penis? This second history is very, very, very important, especially the red and painful eyes, history of sexual behavior, first discharge from penis, and chronic skin disease such as psoriasis, as well as you look for the skin disorder including your soles. You cannot leave just skin in the external aspect, what are the visible area, even you have to look for the soles also. And history of tuberculosis, past history of tuberculosis or contact with an open case of tuberculosis. These are all very important things. Here we are going to make a diagnosis as well as you are going to exclude the diagnosis. And another things we have to do, genitalia. Is there any pain in the testicular pain, testicular tenderness? These are the children, adolescent, especially adolescent, they have a hesitation to inform you about it. Unless you ask, they will never come up with that. And another things, it is there may be only joint. The complaint may be only joint pain. You need to look for any fasciitis or tenderness, tendinitis is there. Lot of things we need to ask, especially in an adolescent kid. As a development pediatrician, we always, by 3 years, we explore our own genitalia. By 17 years, we'll try to explore the opposite sexual genitalia. So these are the things we need to consider. Please, next, madam. So for investigation, so why should I go for all these things? These are all basic things. By complete blood count and peripheral smear, coagulation profile, ESR and CRP, tuberculin skin test, chest X-ray for tuberculosis, synovial fluid, HIV and VDRL. Of course, I know it is for 17 monojoint, single joint, a large joint involved. So I know it is going to be either tuberculosis or it could be a sexually transmitted. And considering the percentage, we need to know with the new terminology called sexually acquired reactive arthritis. For postgraduate, it is called SARA. It is easy for you to remember SARA. Okay, SARA, the incidence of SARA is almost like 4%. So it is not very uncommon or something. I'm not very sure about the Indian prevalence. Various studies I gone through that shows 4%. And very importantly, in these cases, we need to ask for the history of sexual exposure. They may forget it sometimes because these kind of problems are not going to happen immediately after that actually. And we need to know what is the incubation period, what is the clinical pattern of this, because it's a typical reactive arthritis. When we study microbiology, always combine the triad of that, arthritis, uveitis. So the triad is always there. We call it Ratus disease. Nowadays it's been labeled as a SARA. Next, madam. So always ask for a history of unprotected sexual contact about 5 weeks prior to them. Sometimes it can go even up to 5 weeks to 3 months also accepted. And it typically, the arthritis will develop for 2 weeks after the genital symptoms. So the child would have forgot about it. 3 weeks back, expression something, so it would have happened. Obviously, they will never come out. Even instead of keep repeatedly asking, they are not going to come. And genital problem would have been a testicular pain or anything would have been managed with some paracetamol or anti-inflammatory drug some 2 weeks back itself. Now the child will be, because the child is the adolescent child may not be able to relate all these things, they may mask it actually. So we need to keep on asking about urethral discharge. In female, it is opposite to the cervical. Another thing I want to mention, in rectal, the sexual transmitted disease can present rectal infection also, which is actually not going to be present except for a discharge or bleeding from the rectal area, which also to be considered in these cases. So these are the very important, and very rarely they can involve your cardiac system, renal system, it can involve neurological system. So always extra-articular examination is very important, especially for skin manifestation. It may be psoriatic, it may be like a geographic tongue, or it may be a keratoderma blennergia in the soles actually, or it may be a simple conjunctivitis, or as well in the musculoskeletal system, always go for entities, fasciitis, and low back ache also you have to look for it. These are the important things in an adolescent age. So the diagnosis is going to be reactive arthritis or Rita's syndrome. That is a very common thing we have to come across. It is actually another thing I want to say. It is like a self-limiting condition. You have to think about the chlamydia, Neisseria, or some other HIV or any other sexual disorder. Target the disease. It is going to be self-limiting. But uveitis can recur. Even it can go for a blindness also. So the classic trait of urethritis, arthritis, and conjunctivitis should never be forgot actually.
So very important. And I think as Dr. Sudhakar has said, we are now becoming more like Western population, especially in the metros. So whenever you have an adolescent person coming in, never forget to take the sexual history. I think most of the time that doesn't come in our minds, but I think we should make it a point that this is something we should never forget. So this is what I wanted to highlight in this particular case. There are a lot of organisms, as he has described, which can cause reactive arthritis, and investigating for HIV is a very important part of the analysis. So coming to the next case for Dr. Lakhan, a 7-year-old boy has severe pain and swelling of both ankle joints. And he had a viral URI about 1 week back with squarey, some rash over the buttocks. So Dr. Lakhan, what do you think this child has? How will you confirm? Any investigations you'd like to do that will help you? Dr. Lakhan, you have to unmute. We can't hear you.
Yeah.
Yes. Yeah.
Sorry, this child has a history of fever about 1 week back, and that is perhaps some infection, could be a bacterial or viral infection, and that has perhaps triggered this skin manifestation, as you have said, rashes in the buttocks and arthritis. So preceding history of fever and rash and arthritis of short duration, we have to think of vasculitis. The age of the child also fits into the most common cause of vasculitis in children, that is your HS purpura, also known as IgA vasculitis. Uh, the most common manifestation, of course, is skin manifestation. The skin manifestation initially can be in form of your petechiae or macule and urticaria, and later it becomes a palpable purpura and even bully. The pressure points are involved, as in this child, the rashes were there in the buttocks, but lower limbs and shin, they can also be involved. The second common manifestation is arthritis. The most common joints involved are your ankle joints and knee joints, and your hip can also be involved. So, in the short history of arthritis with rashes, and if we consider a triad for the diagnosis of your HS purpura, that is arthritis, palpable purpura, and pain abdomen. Now, the pain abdomen is also seen in about half of the patients, and at times it presents like intussusception. So, ultrasound should also be considered in these cases. Though before finally arriving at the diagnosis of HS purpura, we should also rule out other causes of skin manifestations and arthritis and a history of fever, like your leukemia. We should consider, and that can be easily ruled out by your peripheral blood smear examination carefully. And similarly, we have to think of ITP also. If the rashes are more of ecchymotic and purpuric, though the arthritis is not seen in case of your ITP. So this is a triad which can be all the three manifestations, 3-4 manifestations can be seen at a time simultaneously, or they can appear sequentially. First, there can be arthritis and rash, and there can be pain abdomen later on. And the arthritis of HS purpura is your self-limiting. There is no effusion of the joints. It needs to be given, you can give NSAIDs that, helps a lot. But the most important thing is the renal involvement, which is seen in about 1/3 of the patients. That can present with hematuria and proteinuria. A nephrotic syndrome like presentation can be seen, or acute nephritis like presentation can be seen. So in such cases, we should always rule out renal involvement and GI involvement, because if there is a GI involvement, then steroids are recommended, and at times the children can present with manifestations like intussusception and obstruction. So this is a simple case of IgA vasculitis. Earlier we used to call it HS purpura. Now it is because there is an infiltration of the IgA in the vascular bed and in the soft tissue, and there is extravasation of the fluid in the small vessels. So for the diagnosis, if at all you want to confirm, you can go for aspiration, and you can see for accumulation of the IgA in the tissue.
So what about skin biopsy? Do you think you should do, or is it usually needed, not needed?
Yeah, if you want to confirm, then you, of course, skin biopsy can be done, and you can see the IgA deposition and features of the vasculitis, like extravasation of the fluid. So though it is a clinical diagnosis, HS purpura is a clinical diagnosis, usually biopsy is not required, but for the confirmation, skin biopsy can be done.
So in this very nicely described, Dr. Lakhan, I think what we wanted to highlight here is that it is not a very uncommon presentation of HSP, that you can get significant arthritis and very disabling arthritis. And remember, it's mostly a clinical diagnosis. So, you know, the preceding history of some fever or rash, that is something you have to ask in these patients. So now coming to case number 12, I think this is one of our last cases for Sagar, 12-year-old boy, very high-grade fever with an evanescent rash, as you can see, and hepatosplenomegaly. So what do you think this child has? And an X-ray like this.
So, ma'am, I think the first important thing is you can see that this child has been having fever. So I would definitely want to know the duration. So I presume it would be going on for a few months.
Yes, it's for about 3 months now.
Yeah. So the moment you see a child coming with fever for 3 months, you have opened up a Pandora of differential diagnosis, right from tuberculosis to everything that you can think under the sun. But the only thing in this child that is important for me is the rash, which you have very characteristically mentioned as evanescent. Now, I would want to spend just a minute here saying that whenever you see a febrile child coming with rashes, if the rash is reddish, macular like this, which is shown in this picture, which stays only for a few hours, and as soon as the child becomes febrile, there is no rash, we call it evanescent rash. And I would think of one disease when we start looking at a child with evanescent rashes. So the other thing is hepatosplenomegaly. Naturally, with fever for 2 to 3 months and hepatosplenomegaly, tuberculosis, leukemia, lymphoma, and brucellosis. So I said the long list. But with the evanescent rash like this, one should add to the differential diagnosis systemic juvenile idiopathic arthritis. So that should be at least added to the differential diagnosis. Now, as you move further, you will see, so ma'am, next slide. So this X-ray, obviously there is obvious cardiomegaly, but this is actually pericardial effusion, and it was confirmed by echocardiography. So you can see this child also has serositis. And again, TB can present with pericardial effusion, but again, systemic GIA presents with pericardial effusion. So effusion or serositis is another manifestation. So you can see TB will be a very close mimic, or sometimes lymphoma is a very close mimic in this setting. The next slide, you would see that this child has fever, rash, serositis, organomegaly, very high inflammatory parameters, and a huge number of differential diagnoses. But once we did a bone marrow exam, which was negative, tuberculosis workup was negative, persistently elevated inflammatory parameters, this is systemic juvenile idiopathic arthritis. I'm sure you would be asking, where is arthritis? This child, you never said that there is arthritis. So this is one form of juvenile idiopathic arthritis wherein you may not have arthritis right at the beginning. So some can even debate the name of the disease. But what I want to say is, when you have a febrile child going on for months with very much elevated inflammatory parameters, some organomegaly, think about systemic GIA. And if you have excluded your routine possibilities, giving one antibiotic after another will never benefit these children. Now, What would benefit is sometimes a course of naproxen, which is NSAID. They quickly respond, but eventually most often they would need steroids. So systemic JIA is a condition wherein you have arthritis in any number of joint, even single joint, but most often they would have few joints involved. The fever duration by definition should be at least 2 weeks. So if you have any febrile child with arthritis, you can always keep this as a differential. But if they have evanescent rash, organomegaly, serositis, then your possibility becomes stronger. And once you have excluded other conditions, you can proceed with treatment. Now, why it is important? Whenever we discuss GIA, juvenile idiopathic arthritis, we always talk about morbidity. We hardly talk about mortality. A child with psoriatic arthritis would essentially keep suffering, but don't essentially die of the disease. But systemic GIA, we all are scared, because if you don't diagnose them in time, sometimes they'll end up in what we all call them as HLH, the hemophagocytic syndrome, or in rheumatology, they call it macrophage activation syndrome. So imagine a child with somebody who comes with fever, arthritis, and he comes to you very sick and is having cytopenia, very high ferritin. This is macrophage activation, which has developed on the background of systemic GIA. So don't miss this disease, because this is one disease which is not forgiving. We have lost children with MAS due to systemic GIA.
Yeah, and I think there is a very good paper from one of our colleagues, Dr. Priyankar from Kolkata, probably with the highest number of macrophage activation syndrome in GIA. So I think if you have time, especially the postgraduates, should go and read this paper. So very, very important point. Yes, Sagar, you wanted to say something.
I'll also want to highlight that in India, enthesitis-related arthritis and systemic GIA are the most common forms of GIA. Oligoarticular GIA is the most common in the European continent. And that's why most of the textbooks would say oligoarticular GIA is the most common, up to 70 to 80%. But we all know from our practice and from publications in India that it is ERA, enthesitis-related arthritis, and systemic GIA, which form the majority of the chunk, more than 50% of our patients.
Yes. So unremitting fever, rash, it's very difficult to see a rash in our kind of a skin color, but then you must keep it in mind that if it is an unremitting fever, then it could be the first presentation of a systemic onset GIA, though it is a diagnosis of exclusion. And many of these patients, in the experience of the rheumatologists, pediatric rheumatologists, is that the first presentation can be with a macrophage activation syndrome. I remember reading a paper by Dr. Sujata Sawhney when she published when she was in England, and it was mostly on the patients of systemic onset GIA. So very, very important disease to be kept in the mind. And I think now we are having even general pediatricians and intensivists diagnosing macrophage activation syndrome very commonly. So we have come to the end of the cases that we have discussed. And I thought before we leave it to the chairperson, a little bit on the comments on labs in arthritis, because there are many things which, we do generally, like if the patient comes, we land up writing, but are these really useful or not? So I'll start with, again, in the same sequence, first with Dr. Rajsekhar. ESR and CRP, what is the utility? Is it really useful? Since, in our cases also we have written ESR, CRP so often, given values which have been very high also. And how do we interpret them in the clinical setting?
Yeah, first of all, one should get in mind that just looking at ESR, CRP will be quite a diagnosis in arthritis. Everything has to be taken in account. But few lines I'll be telling about the ESR and CRP. You have to include the history, you have to include the examination, you have to include the ESR. Then you come to a conclusion. Suppose we have been given only ESR and CRP. So number one, I'll be dividing it in a case of infection. Then I'll be dividing in a JIA. Then I'll go into the vasculitis group. Suppose I have been given only ESR and CRP. Coming to the infection, what are the common infections? It may be an acute septic infection or it may be chronic tubercular infection. If it is an acute septic infection, CRP, ESR are both placed. If it is a chronic like tuberculosis, most likely ESR will be on the higher side than the CRP. Then coming to the group of the JIA. In case of JIA, oligoarticular arthritis, CRP and ESR usually normal. When it comes to the polyarticular arthritis, ESR, CRP are on the higher side. When we come to the SOGIA, it is most of the time it is high, very high. Thrombocytosis, then there is the ESR high, CRP high. SLE, when it comes to SLE, CRP will be normal, ESR will be raised. So this is coming under the GI. Then we are coming into the vasculitic group. Suppose it is an HSP related arthritis, ESR and CRP usually they are normal. Coming to the PAN, where polyarticular nodosa is there. There also arthritis is there, systemic fever is there. There ESR and CRP will be high. Then at the last Takayu's arthritis, basically the arthritis group, only ESR will be in a 3 figure, CRP will be normal. Then the final arthritis is malignancy. In the malignancy, ESR will be very, very high compared to the CRP. Thank you, madam. These are the groups I have evaluated.
So basically we must understand that ESR indicates ongoing inflammation, but it will always be affected by the level of hemoglobin. And very important is that if you are having a macrophage activation syndrome, then the ESR, if it's a sick child, even though the child is very sick, the ESR will not be raised. And probably it is more useful to monitor the disease rather than to use it as a diagnostic tool. Similarly for CRP, I think you have already described, and mostly in GIA, it will indicate the disease severity. Also, it is a predictor for the development of amyloidosis, and high CRP in SLE will indicate an infection. Coming to Dr. Sudhakar, what about ANA? When to use, what type of analytical method, interpretation if you have a positive ANA?
When I come to interpret this kind of things, I feel like a football player playing in a cricket ground, actually. Thank you, Dr. Sagar, for giving another information for me. Okay. Coming to ANA, for a pediatrician, whenever you think about rheumatological condition, that is a criteria to think about ANA. ANA, it could be using as a screening test, and except for SLE, other things, it's a screening tool. It is not a diagnostic. It is very important to note that autoantibodies are only markers of a disease, and they cannot be considered as a gold standard test for diagnosis of all the rheumatological disorders. Next, madam. So whenever you suspect a connective tissue disorder, you have to think about it. For the type of things, there are a lot of methods are being. I don't know what are the methods available in India, but we know it's ELISA and immunofluorescence are available in India. So we all immunofluorescence, indirect, especially indirect immunofluorescence, the gold standard among the ANA testing method. ELISA has generally discussed it is a sensitive, but not specific. Even about the sensitivity, what I have read is it's a low sensitivity. And it really definitely it is not going to be a specific thing actually. So what are the conditions we have to think about? These is SLE, Sjogren's syndrome, mixed connective tissue disorder, all type of scleroderma, journal dermatomyositis, and uveitis with JA with uveitis. And when I come across things, any negative rheumatological conditions will be dermatomyositis and polymyositis, vaginous granulomatosis. These are things which can come as a negative ANA, as well as we have to work on that if there is a clinical parameters are there actually. So this is how my next statement.
So do you think ANA will come positive in the normal population?
Madam, actually it is very clearly good, even up to 5%. Yes, normal people also can have an ANA positivity actually. But SLE, it is very characteristic in SLE.
So I think many a times you'll end up writing ANA, and then if it comes positive, we really don't know what to do with that report. And then it becomes very confusing. Of course, it's good that you'll end up sending the patients to the pediatric rheumatologist. But I think when you order an ANA, you must be really clear in your mind why you're ordering it. And many a times I see that people order ANA and dsDNA together. So what is your comment on that, Dr. Sudhakar?
What's
ANA plus, many times people just write ANA plus dsDNA. So
the thing is, whenever you write some, dsDNA, ANA itself is enough for SLE, but if you are very specific about that, go for dsDNA. And dsDNA is, as a pediatrician, dsDNA is not going to be much helpful to write other connective disorders actually. So Sjogren's syndrome, all those things, I don't know. SLE, of course, it is going to be helpful for us actually.
Sagar, you want to comment on this?
Yeah. Okay, ma'am. So basically, anti-nuclear antibody are antibodies against the nuclear antigen. Inside the nucleus, there are several antigens, say more than 100 antigens. So when ANA comes positive, It means the body has produced antibodies against nuclear antigen, which can be dsDNA, which can be histones, which can be ribonucleoproteins, RNPs, so many nuclear antigens. So if the ANA is negative, there is no point in looking at what antibody is. Is it anti-dsDNA, anti-histone? That means anti-dsDNA, anti-histone, this question only arises when the ANA is positive. If the ANA is negative, then I would not look beyond ANA. So it is like there is no role of doing a ANA profile if the ANA is negative. In the same way, essentially, I would not order an anti-dsDNA if the ANA is negative, as a broad principle for pediatric practice.
Excellent. I think that is the point we wanted to make. Here, Sagar, I'd also like to ask you one thing. Nowadays, we have a test called ANA reflex. What is your comment on that?
I'm sorry, ma'am, you should update me. I am not aware of ANA reflex.
Okay, we'll leave that to the chairperson because we should not discuss everything.
Okay.
Okay. So, Dr. Lakhan, what about radiology? What would you like? X-ray, ultrasound, MRI? If I'm given a choice, I have a patient of joint pain coming to me.
Ma'am, in case of arthritis in children, the radiological findings are usually they lag behind the clinical manifestations. So we should rely more on our history taking and physical examination. Most of the times the diagnosis can be made by the proper history, especially the family history, past history, and evolution of the symptoms, and your physical examination. If like in some of the benign conditions, like in the first case when there is a pain due to exertion and a non-specific arthralgia, in those cases, if at all you want to go an X-ray of that particular affected part would be enough just to satisfy the parents, because it could be a benign condition. And in those cases, advanced investigations like MRI should not be ordered. But if there's a real arthritis, and if you are confused whether there's associated septic arthritis also like in a small child, then of course X-ray would not be able to tell the details. In that condition, I would recommend for MRI, because beside the synovial inflammation, with the MRI we can know about the effusion in the joint and about the adjacent part of the bones like metaphysis. So if there's arthritis and you are suspecting septic arthritis, osteomyelitis also, in that condition, I would recommend for MRI, and that can give you the details of the soft tissue, about the injury, about the ligaments, about the synovium. But in few cases, of course, when there's a long history, then X-ray can also be useful. As I mentioned in my case of sickle cell disease, when there was possibility of avascular necrosis of the femur, then X-ray findings will come little late, and in those situations, of course, MRI will pick up the avascular necrosis quite early. So MRI, of course, is very sensitive and is more elaborative as compared to the X-ray. Of course, effusion can also be seen by ultrasound. But the most important message is the clinical diagnosis is the most reliable thing we should do in the clinical practice.
I think very good points. Though we have all kinds of radiological investigations with us, we must be very justified in choosing which will be beneficial for our patient. Because if you know you can diagnose it with an ultrasound, then probably you'd avoid an MRI looking at the cost. Sometimes you would avoid radiation and try to do an ultrasound or an MRI. So very nicely elaborated. And I come to the last very important question for Sagar. Many a times you have a rheumatology panel being ordered, even if the patient comes with arthritis. So what is your comment on this utility versus wastage of resources versus confusing ourselves?
Ma'am, there are two things I would want to state here. I'm sure you have done panel discussions for last 15 to 20 years. I must be only involved in last 2-3 years. And this slide you must have discussed maybe 100 times. I would only be happy if this slide reaches people and we really stop wasting resources. That's number one comment, because sometimes I think it is more often discussed than practiced. Number two is, I think it is easy to remember 5%. 5% of normal people can be ANA positive, especially even in children. 5% of people can be RF positive, even if they are healthy. And only 5% of children with JIA or rheumatoid arthritis have RF positivity. So what does it mean? It simply means that by doing this test, I gain nothing. There is a child with pyrexia of unknown origin. I do a rheumatoid factor, it comes back positive, and we have confused ourselves, because RF can be positive in tuberculosis, syphilis, infective endocarditis, anything that you name under the sun, RF can come back positive because it is an antibody. So what it only means is that there is nothing called a rheumatology workup. If we have asked a rheumatology workup as a panel, then we have put ourselves into more difficulty. And these days, with parents going and Googling, you are supposed to read more and answer more. So it is better not to be done if we don't know why we are doing it. And second thing is the ANA profile. I think somebody was asking, why should we do it? As we have already highlighted, when you do a ANA by immunofluorescence, it may come back positive. The next question naturally is, what are those antibodies to which ANA has come positive? So that is why I asked for an ANA profile, because the profile contains all those antibodies. It may be 13 or a list of 15 antibodies. And based on the antibody specificity, I can diagnose a condition. ANA positive, anti-dsDNA positive, I am surely leading towards SLE. But if the ANA is positive, dsDNA, Smith, everything is negative, maybe this ANA has only confused us and we have not gone anywhere. So the profile is very important when the ANA is positive and you're thinking about a connective tissue disease. As I've highlighted, no role of rheumatoid factor in pyrexia of unknown origin. None of them is a diagnostic test. If there is a high pretest probability, these tests are going to help us, or they are going to confuse us more than we thought. Thank you.
Thank you so much. I think we've come to the end of our discussion and we are on time. I must thank all of you in this very short time. We have not, maybe we have not discussed all about arthritis, but at least we have discussed a lot of things about arthritis, both from benign to malignant conditions. So with this, I thank the organizers for giving me the opportunity to moderate this panel today. It's been a learning experience, preparing and also listening to all of you. And I'd like to hand over the proceedings to Dr. Suma, the chairperson.
Thanks, Rashna. I think this was a phenomenal panel discussion, actually. I quite enjoyed the whole thing myself. I think, there are a lot of the questions that have come up in the chat have actually been answered during the discussion, but there are a few things that I think is worth going through again. So one person asked a question, the second case where the patient had polyarthralgia and high ASO, could that be a post-streptococcal reactive arthritis? I think the discussion has already borne out the fact that we do not make a diagnosis of arthritis based on arthralgia. But perhaps anyone on the panel could like to highlight this, this point. Dr. Sudhakar, maybe?
No, I didn't get, but pardon me, please repeat.
No, there's a question. The second case that you discussed, the child who had a high ASO titer and polyarthralgia, no other findings. So someone wants to know whether that could be a case of post-streptococcal reactive arthritis.
Yeah, it could be. It is one possibility is a reactive arthritis, but the point is there is no arthritis. In the case scenario, it is only arthralgia has been mentioned. No restriction of movements has been mentioned in this case.
Yes, I think that's well said. I think the important thing here is that we should never confuse a ASO titer as diagnostic of rheumatic fever or of PSRA. That should be the real point. It's the clinical context is very, very important. Unless the clinical context and the findings are there, then that's not significant. There's another question. Oligoarthritis, does it affect the same joint every time? Do you want to take that, Sagar?
Not necessarily. Oligoarthritis, see, I would say the term oligoarthritis means maybe 4 or less than 4 joints, and there could be a lot of differential diagnosis. So we always say arthritis is not a diagnosis. It is somebody like saying your final diagnosis is fever. So arthritis is only presentation. and you will have to give the diagnosis. And when I say oligoarticular GIA, I'm giving a diagnosis to a child with arthritis. So children with oligoarticular GIA or oligoarthritis usually present with lower limb predominant arthritis. Most commonly, I would say ankle and the knees, and it need not be in the same joint. But unlike we discussed in hemophilia and bleeding disorders, there could be target joints. And once they start getting affected, usually the same joint keeps having I'm saying keeps getting affected again and again. But that's not a phenomenon that you see in GIA.
Thank you, Sagar. Now, what about the usefulness of anti-CCP antibody in the diagnosis of JIA in children? I know you've mentioned it, but I think reiterating the point would be good. Sagar again.
Yeah. So basically, let us see how these things evolved. It's all. So we have all derived this from the adult practice. So basically what happens is rheumatoid arthritis, which is the most common form of arthritis in adults. It's quite prevalent. People say 1% of the population. That means it is quite rampant in adult population. So what happens is 70 to 80% of them are RF positive, rheumatoid factor positive. And a proportion of them are actually RF negative, but have very classical presentation like rheumatoid arthritis and are anti-CCP positive. So what happens is even if your RF is negative, anti-CCP is positive, you are going to treat them as rheumatoid arthritis. That is the standard of care in adult practice. Now, when it comes to pediatrics, as I said, only 5% of children who have symmetric polyarthritis are going to be RF positive. And then there may be a very small percentage who are RF negative and anti-CCP positive. So I wouldn't really put my money into anti-CCP until I really want to. But the thing is, if you have symmetric polyarthritis, even if RF is negative, your treatment will start with methotrexate and go on further. So you can always do an anti-CCP, but then not a lot of studies in children and no much addition in treatment, I would say.
Thank you, Sagar. I completely agree with that. I mean, in more than 10 years of practice, I must have ordered an anti-CCP maybe 4 or 5 times in total. So I think that would be the usefulness of that. Now, I think we've been through things like, Sagar, do you want to say once more why CRP is not raised in SLE?
So I think the other day some pediatrician again called me and asked me and I had to read about it. So I think it is easier said than explained in detail. I would just say one thing. These days, everyone knows about COVID. So everyone knows about interleukin-6. Everyone knows about tocilizumab. So my answer becomes easier. I'm saying. So what happens is you all know that in COVID with severe illness, interleukin-6 goes up, CRP goes up. So whenever interleukin-6 is produced, say in the lungs, it goes to the liver and the liver starts producing CRP. So this is the normal thing that should happen. But what we know in SLE is that something called type 1 interferons are very high. And whenever they are very high, this pathway is blocked somehow. The STAT3 signaling, I don't want to make it complicated. Basically, the IL-6 mediated pathway is blocked so that these patients are unable to produce CRP. This is a simplistic explanation. And it helps in clinical practice because if I have a follow-up of SLE who develops fever and comes to me with very high CRP, I'm likely looking at an infection rather than a disease flare. I think that is the most important utilization of CRP in SLE.
Excellent point. I think many of the questions here have actually been covered during the discussion. I think the earlier pointers of systemic JIA, they have actually been covered. Use of ANA profile in pediatric SLE, I think Sagar has been very, very clear about that. So we've had a long discussion, and if there are no other questions, we can possibly, yes. Is Lyme disease common in India? And is there a differential diagnosis for migratory arthritis in India? Dr. Lakhan or someone would like to take that?
Yes, Lyme disease can cause migratory polyarthritis. Similarly, chikungunya can also cause migratory polyarthritis. So rheumatic fever is of course the common cause of migratory polyarthritis, but Lyme disease can, I don't have any experience of treating Lyme disease. So how common Lyme disease is, I can't comment. I think Sagar would be the right person to comment upon that incident.
I would even ask Dr. Rashna and Dr. Suma ma'am to talk because in my limited practice, I have hardly seen Lyme arthritis, but I feel we may be missing it because we are not rampantly testing for it. And the serology of Lyme is very challenging to my mind. Even if it comes positive, it does not always mean Lyme arthritis. So you should be very careful when you ask a Lyme serology. That is what I can tell, because after a discussion, you go back and ask a Lyme serology, it comes back positive, doesn't mean Lyme arthritis. So there is that's the painful part of Lyme arthritis, I can tell you.
I think more than Lyme, it is chikungunya, which is very common.
Yeah.
Yeah, all over the country, you look from West Bengal to Kerala, everywhere. I think chikungunya is something which is coming up. Suma, what about your experience of chikungunya that side?
Yes, I think right now it's down. It is, the incidence has really come down, but it was a very big problem about 10 years ago. Children were far less affected compared to the adult population. The other thing is that in Kerala, from the hilly regions, like Idukki and Wayanad area, they have had reports of Lyme arthritis. I presume those are tick-infested areas, and it is possible that you can get it. Again, the reports are more from adults than from children. So I guess it is there, but it's not really as common as reported in the Western world.
So Suma, I had asked Sagar one question.
Yes.
ANA reflex.
Yeah, I didn't expect you to give me a googly like that, but then yes. Yeah. So basically, the idea of ANA reflex testing is, it is a concept of, cascading hypothesis of testing. So this concept actually came up in Western labs, where it's generally the general practitioner and more in adult practice. So the general practitioner sees the patient and he wants to do as much as possible in one visit. So the labs have this concept that they will do an ANA first. They do it by immunofluorescence, and there are two types of reflex testing. So one is based on the ANA pattern that you see on immunofluorescence, whether you see a homogeneous pattern, whether you see a speckled pattern, whether you see a cytoplasmic pattern, etc. Now, each of these patterns are expected to correlate with one particular kind of extracted nuclear antibody. So then the idea is that the lab looks at the pattern on the ANA immunofluorescence screen, and then does that particular antibody in cascade if the ANA is positive and that particular pattern is seen. So hopefully that the patient gets both results in one go, rather than having to test twice at two different times. The second way of doing the reflex is by looking at the clinical presentation of the patient. So is this patient presented with, say, Raynaud's phenomenon, or is this patient presented with features where you would associate with scleroderma, or with dry eyes, dry mouth, etc. In which case they would do the ANA, and if it's positive, then they would do the representative antibodies of that particular disease. They're looking at Sjogren's, they'd look at Rho and La. If they're looking at scleroderma, they'd go for the anticentromere, that sort of cascade. So the thing about the cascade ANA is that, first of all, in pediatrics, I think it is very, very impractical. And it's not, the idea is that the diagnosis of SLE or of connective tissue disease, it's not really that, your ANA gives you the diagnosis. It's actually the clinical examination, the history taking, the clinical pattern, phenotype, your general tests, everything that you're doing, that gives you a pre-test possibility. And then you evaluate the patient and get on with your ANA and your antibodies. So rather than, be very flustered about, which antibody should I order? The simple thing is, look for the clinical phenotype, try to recognize it, have a pre-test probability. Yes, I think this patient is quite likely to have lupus, and therefore I will do an ANA by immunofluorescence. I will request for the serum complements, and if that comes positive, then I would consider doing an anti-dsDNA or an ANA profile. So it depends on, that is probably the way to go about things. So yes, the reflex does exist. I think it's more of a lab promoted concept rather than a physician promoted concept. Is that okay, Rashna?
Yes, I think excellent
I was
way
doing
to
I
describe.
was doing a quick lit search because you asked me, and I realized that thyroid function tests are classically
Yes.
run on this.
Yes.
So I think
Cascade
that is the
pattern.
concept
Yes.
where they derive it. Yeah.
Yes.
No,
And we
because
have
this is
seen the-
something, you know, the lab will tell you. So before people start using it, I wanted that it should come out in this discussion. Because there's always a tendency, you know, like the rheumatology panel, reflexly, you know, you'll start writing.
We have seen
So
the
I
reflex testing in case of inborn errors of metabolism these days. If you order a TMS in a child whom you are suspecting IEM, if something comes positive in TMS, they will automatically go for gene analysis and further testing. So this is reflex. If something comes positive in a screening test, then the further detail analysis they will do automatically. This is perhaps the concept of reflex.
Okay. I think that's great.
Yeah, we're on time.
Shall we stop? Yeah.
Yes.
We can stop now if there are no more questions. We'll kind of exhausted the questions, I think.
Yes. Dr. Remesh, is he around?
No, I think he's left. So, Dr. Balachandran?
So thank you. Yeah, I am here.
Would,
I am here.
yeah. Would you like to
So
conclude
thank
the
you
discussion?
It's okay, so ma'am, we will have the vote of thanks and we will wind up.
Yes, thank you. Yeah.
So
I would like to
today
take
we
an
had a
opportunity to thank
very-
Dr. Rashna, our moderator, who made us to work for the last 12 hours actually. Yesterday night, by 12 o'clock only, I opened the questions and sent the answers by 1 o'clock.
Thank you. Thank you.
Yeah. Thank you for making us to think about from the pediatrician point of view. I thank all my colleagues, panelists for teaching us a lot. And I have found a young chap, Sagar, very informative. All the best for your future.
Thank you.
Thank you, Dr. Rashna, and thank you, Dr. Suma, madam.
Thank you.
Thank you, and all the best. And thank you, Kerala IAP.
Thank you. Today we had some 250 plus audience, including in the YouTube. In spite of the IPL, I think it's a good number. So today we had around 12 case discussions on various aspects of children with limping gait. And Dr. Rashna Das, as ma'am, have done a very good job of moderating this excellent session. Thank you, ma'am.
Thank you.
And all the four panelists has done justice to this discussion. Very interesting discussions by Dr.Lakhan, Dr. Rajsekhar, Dr. Sudhakar, and Dr.Sagar. And looking forward to see you all physically at least next year in Kerala. And I thank all the four panelists. And Dr. Suma Balan chairing this session is like icing the ice, less like icing on the cake. And thank you, ma'am.
Oh, hi,
Your
Ramesh.
expert opinion.
Bala, I'm here. I'm sorry, I had a Zoom session parallel which came up from Dr. Santosh and others, but it was unfortunate. I listened to halfway through, but I could not complete it. And thank you so much, all of you, because Dr. Rashna, and at a short notice, you have done a great job. I was almost 80% I was through, but last since 9:15 I have to be away for some 30 minutes. And thanks so much to Suma ma'am for taking it through. My great friends right here, Dr. Rashna, apart from Rashna ma'am, Rajsekhar, Sagar, Lakhan, and Lakhan has been great, and Sudhakar. And thanks to all our participants for being with us. Wonderful questions. I could say a lot of bombarding questions on the platform, which are really encouraging for all of us to take it forward. And they have learned quite a lot interactive platform. And in spite of going past 10 o'clock, I feel not many were just loading. Still, that's great going for all the IAP, I think, academics in a big way. Thanks really a lot. And Bala, please continue. I just joined. I thought I finished the
So as a formality, I thank our President Narayan sir and our scientific coordinator Remesh sir also for starting this vibe sessions. And I thank all the seniors and my friends from Kerala as well as outside Kerala who has joined us for this discussion. Thank you all. Jai Hind, Jai IAP.
Thank you, madam. Thank you.
Thank you so much, IAP Kerala and Dr. Remesh. And I wish best of luck to Dr. Remesh for his endeavor.
Yeah.
Thank you. We are together. IAP family is going to be the winner, not anybody else.
Best of luck, Dr. Ramesh.
Thank you. Thank you, sir.
Thank you, everyone. Thank you, madam. Thank you, Rashna, madam. Thank you all the
Dr. Sagar,
panelists.
being from developmental pediatrics, you did a great job.
Yeah.
You were talking about sexual abuse, something different, male, but that was really encouraging. That's what I told Rashna ma'am. It's not only a rheumatology perspective. Perspective has to come from the general pediatrician. Lakhan is there, Rajsekhar is there. They are all, apart from Sagar, all others are from general. Means they are doing general pediatrics, and that the clunge of the patients come to them only. They only take it to the rheumatologist or may have to come to the rheumatologist. So the primary perspective of the pediatrician can be better understood by them, and you all come in the secondly on the picture. So that's really great. Thank you.
Thank you for the opportunity, sir, to make us read something.
We are privileged having you all around. We are really privileged having you all around. And I must
hats off for you to motivate us to read something.
What else can we do? We are all here really to encourage each other and get going. That is our primarily this platform. IAP itself is meant for this only. And I always believe in being going along. You first and I second. So we are all together. And I am always with you only. And Rashna ma'am, you did a great work. Thank you.
Thank you. Thank you.
And
Actually, thanks to the panelists. They were very cooperative.
I saw the WhatsApp communications. I was also there and I was a little apprehensive. I got to you a little late. So I should be apologetic that I was just hiding behind the scene that I should not come forward. I didn't give you enough time. So I was worried how I can face you. But still, it's just a wonderful talk taken well. And Dr. Suma also, thank you so much for taking it through. Bala, thank you. Good night.
Thank you, sir.
Good night, sir. Bye. Thank you.
Bye.
Thank you.